Hello, and welcome back to another lecture video. My name is Carlos Brian Francia, and today we're going to be learning about blood. So this is basic hematology, and hopefully in this video we can cover erythrocytes, leukocytes, the plasma, the proteins inside the plasma, and some basic immune responses. Alright, so here we go. When we draw blood from the body, what do we see? We see something that's red. We see something that's slightly thick and sticky. But when scientists take your blood and they put in the little machine that revolves it quickly, that's a centrifuge, they get layers of this blood. And here are the layers. When we separate the blood in a centrifuge, it separates into 3 different layers. The bottom layer is the most heaviest, and it's called the hematocrit. The hematocrit is actually just the red blood cells. Another way that we can name red blood cells is through erythrocytes. And typically hematocrit is given in a percentage. So for women, it's a difference of 10%. So on average, a woman may be between 40% hematocrit or 42% hematocrit, whichever. And that must mean that when you take a vial of blood from this person, let's say 42% of that overall blood is red blood cells. Blood, what we call blood, is just made of 3 different things, 3 different layers. You have the red blood cells, you're going to have the white blood cells, also called leukocytes, you have the platelets, and then you also have the water portion, which is the plasma. The plasma is like 92% water. It's mainly liquid, but we care about the plasma and we donate plasma because it has different proteins, which we will talk about in a few minutes. So the plasma is a majority of this blood. When we donate plasma, we can replenish that plasma in 24 hours. However, when we donate hematocrit, red blood cells, it takes about 5 weeks to replenish those red blood cells. So this takes longer to regenerate than just liquid and proteins. But between the plasma and the hematocrit is the buffy coat, and that's going to be dealing with your immune system. It also helps you coagulate. So if you get cut, the platelets inside the buffy coat, they're going to come together and hold hands and, make a natural bandage over that cut. Now, we see that within normal blood we have different percentages, and this varies to person, how much water you drink and how stressed you are. Those also play a factor in the amount of red blood cells you have. When you're doing blood work, you may see a percentage called, hematocrit. And for one patient, it might be 38%. And for another person, it might be 32%. We can see that if this person's a man, 32% is way below 42. And we call that anemia because that is depressed hematocrit. If we were to take this person's blood and separate it, we would have a little bit of red blood cells. If we have too much red blood cells, let's say we get a bodybuilder and they're shooting up with erythropoietin, well, this is an elevated red blood cell count. And this is bad because the more red blood cells you have, the thicker the blood is, and the heavier it is to circulate in the body. And so the heart has to work faster and harder to move this blood in the body. So when you add stress to the heart for a long time, you risk your chances of getting a heart attack. And the blood pressure is constantly elevated. Going back to a picture of the blood, right now we're going to be focusing on the liquid portion, the plasma. So this yellowish portion right here that you see, everything suspended inside, well, that's the plasma. It's the liquid portion, and it has proteins, and lipids can fly around and be transferred to different tissues, and that's through the liquid of the blood. So what kind of proteins are inside the plasma? The first major protein inside the plasma, first of all, we're going to call these plasma proteins. And the first one is called albumin. Now, some books will give you percentages of, X amount of percentage in plasma is albumin. Don't memorize percentages because you'll drive yourself crazy. Instead, albumin is going to be a large amount. So it's the largest amount of protein in plasma. So it is the major protein within plasma. What does it do? Well, when we inject steroids into our body, steroid is a lipid-based molecule, and so the plasma is mainly water. So you would expect the steroid to not travel as efficiently inside the blood. However, albumin acts like a taxi for that steroid. So the steroid will enter the blood cell, let's say the artery and then a capillary, and it's going to enter this protein. So what we can say is that albumin is a transport protein. So transport protein. And in addition to that, we can say that the albumin is made in liver. Another thing that albumin does is that it is a major significant contributor to maintaining osmotic pressure. So maintains pressure and water in blood. Ooh, there we go. So for instance, let's say that we have this capillary, and inside this capillary are the red blood cells, right? The erythrocytes. And then we're going to have, let's say, albumin. Let's make that teal. Well, here, the blood always wants to maintain a certain level of water inside of it. And so it will draw in water from the tissues. Let's say that this is in the tissue. It needs more solutes. The more solutes you have, the more water will be drawn in. So if we have more albumin, or more red blood cells, more whatever inside the capillaries, the water is going to find this attractive and go into the capillaries or into the arteries. So let's add some more albumin. Let's just kind of speckle this around. So now we have more solutes. The water is going to find this attractive and enter the capillaries, and thus we have more water here. When you have more water inside a tiny tube, the blood pressure goes up. The blood pressure goes up. Since you have more water coming in, guess what? The blood volume also goes up. And so albumin maintains the pressure and the water content within the blood. So it is the largest amount of protein inside the plasma, and it also acts as a transport protein. So steroids can use albumin as a taxi. And remember when we were learning about hormones, thyroxine and triiodothyronine, they use albumin as a taxi, and they wait inside albumin until the body needs them to activate. So that's albumin, and it's also made in the liver. The next plasma protein, well, they're called globulins. They're called globulins. So what are they? There's a second most protein in plasma. So after albumin, we have globulins. And globulins also act as a taxi, but specifically for iron, lipids, and for 4 vitamins: vitamin K, vitamin A, vitamin D, and vitamin E. And notice I spelt a name. That's Cade. That's the easiest way that I found I can remember these vitamins. These guys right here are fat soluble. So the body will store vitamin K, A, D, and E inside your fat cells. Globulins are made in the liver. And there are actually 3 types of globulins, that being the alpha globulin, the beta globulin, and the gamma globulin. Well, alpha and beta globulins act as transporters, and maintain oncotic pressure. So you can say osmolarity. Let's say osmolarity, just like albumin. However, what's a gamma globulin? Well, a gamma globulin is a bit different because it's actually an antibody. It's an antibody. This guy right here is going to be involved in the immune system. So this is actually the immune response. And it's made differently. It's built different. This guy right here, he's actually made in bone marrow, specifically red bone marrow. And the cells that make it are called plasma cells. And we'll hear more about them later, but for right now, plasma cells are found inside the red bone marrow, and plasma cells make the gamma globulin. Gamma globulins are also known as antibodies or immunoglobulins. And the last plasma protein is called fibrinogen. And what fibrinogen does is that it helps in blood clotting. It's also made in the liver. So most of these plasma proteins are made in the liver, except for the gamma globulin, which is made inside the red bone marrow by the plasma cells. So here, made in liver. And fibrinogen is not made that much. It's actually a little bit in the plasma protein. So if we have albumin, and then you have your globulins, and you have your fibros, the clinical level would have to be between 3.5 grams to 5.0 grams of per deciliter. So if we had 10 liters of blood, only about like 4 grams of material would be albumin. So yeah, these proteins are very small compared to the overall volume, but they matter a lot. They are significant. The globulins itself would have to be between 1.0 grams to 1.5 grams per deciliter. And the fibrinogens are very, very small. It's actually 0.2 grams per 0.45 grams of deciliter. So that's the clinical value. So albumin will kind of vary between these numbers. And the more you see them within a clinical setting, when you do blood results, you'll start to kind of see the range and it'll make more sense to you. So fibrinogen's not really a big part inside the blood, but they are important. Everything's important. And you're probably wondering, well, how does the body know when to make albumin and globulins and red blood cells or white blood cells? And that process is called hematopoiesis. It's the creation of erythrocytes, the red blood cells. And where does that happen in adults? Hematopoiesis, which is the creation of red blood cells, it occurs inside the red bone marrow, or the spongy tissue inside the bones. Specifically in adults, it occurs in the skull, in the humerus, which is a long bone, a long straight bone of the upper arm, the femur of the leg, the pelvis. So notice there's so much bone mass. It would be a waste to not use that bone for hematopoiesis. And also within the vertebrae. And notice we have a lot of bones here too. These are the ribs, and each rib contributes to the formation of red blood cells. And finally, we have the sternum. We have the flat bone right here. This also contributes to hematopoiesis. So the skull, the vertebrae, the ribs, the sternum, the pelvis, the femur, and the humerus all contribute to hematopoiesis. When we're a fetus developing, the egg yolk sac is what creates the red blood cells for the fetus. Now, normally, hematopoiesis occurs within these long tunnels inside the bone called the medullary cavity. Medullary cavity, it's inside each bone. However, let's say that this person that we're looking at has bone cancer and they're undergoing chemotherapy and they have medications, or maybe they went through radiation. When you irradiate bone, you're often destroying the cancerous bone marrow. And so now you're taking away the ability to do hematopoiesis from the bone. How does the body still maintain red blood cell levels? Well, it has to do something outside of the medullary cavity. Instead, the liver right here, this big red mass called the liver, and also this tissue right here called the spleen, they pick up the slack. They start making red blood cells, or erythrocytes. And this process is called extramedullary hematopoiesis. So it's the body's backup emergency plan when the bones can no longer perform hematopoiesis. And you often see that within leukemia patients. So first you irradiate the bone to kill the red bone marrow because the blood itself is cancerous. And then they get red bone marrow donors to donate red bone marrow, and that helps the cancer patient. But the liver and this organ called the spleen, they pick up the slack and do extramedullary hematopoiesis. But now you're probably wondering, what is the process of even making a red blood cell? How do we make red blood cells and not white blood cells? And when does the body know when to do this? Well, we're going to go over the hematopoietic pathway. First, we have to talk about the pathway of the stem cells to even arrive at the hematopoietic stem cell. When the embryo first develops, it develops from the zygote. So the zygote is actually the first cell, like ever. It's like the Big Bang. So the zygote is going to be called the totipotent stem cell. Toti means total, and potent means powerful. So this guy right here is the foundation for the entire human body. So we start with a zygote. From then on, the zygote transforms into another group of cells. One of these cells is called the pluripotent stem cell. I'm just going to call stem cells SCs to save time. The pluripotent cell can give rise to different cells. It gives rise to multiple other cells. Pluri means multiple and potent means strong, so multiple cells. Afterwards, the pluripotent cell has to ask itself, what am I going to form? Am I going to form muscle, skin, or nerves? No, let's actually form some connective tissue. So instead of forming muscle or skin or nerves, it's going to be forming connective tissues. And that's for the hematopoietic process. If we were making muscles, the pluripotent stem cells would actually differentiate into muscle cells, essentially. But since we're making connective tissue, which includes blood, the cartilage, and bone, the pluripotent cell is going to create the mesenchymal stem cells. Now the mesenchymal stem cells have to ask itself, am I going to be forming cartilage, bone, or blood? Well, since this is the hematopoietic process, the mesenchymal cells are going to be making blood. And so the mesenchymal cells will differentiate into something we like to call the hematopoietic stem cells. Another name for this would have to be the hemocytoblast, but I like calling it the hematopoietic stem cell. So to recap, we start with the zygote, which is called the totipotent stem cell. it differentiates into the pluripotent stem cell. That's always going to happen. The pluripotent stem cells now has several options. Do we want to make connective tissues, or do we want to make skin, muscle, or nerves? In this example, we're going to be making connective tissues, which include blood, cartilage, and bone. So the pluripotent stem cells become the mesenchymal stem cells, and now the mesenchymal stem cells have to ask themselves, are we going to be forming blood, cartilage, or bone? In this example, we're going to be forming blood, and so the mesenchymal stem cells become hematopoietic stem cells. From then on, the hematopoietic stem cell asks itself, what does the body need? Do we need platelets and red blood cell, or do we need white blood cells? And it actually has two different pathways. But let's say that the body needs red blood cells. Let's say that we have a cut and we need platelets, and after that we lost some blood, so we need red blood cells. And therefore we're going to be taking the myeloid process. So the following is called the myeloid process. Before we even begin the pathway, we have to realize that when we're doing cell division, this cell will split into two different cells, but one of these cells will stay behind. The daughter cell is the cell that's going to be differentiating. We leave this guy behind because we want to always have a hematopoietic stem cell. That starts another cycle. But since we're making red blood cells and platelets and some other items that are not white blood cells, we're going to be doing the myeloid stem cell process. So here we can see the megakaryoblast. We also have a proerythroblast. But notice that all these people right here have blast. What is blast? Well, blast means build. So we're going to be building something. So for instance, monoblast is going to make a monocyte. A megakaryoblast is going to make a megakaryocyte. Well, notice that these guys have cyte. What is cyte? Well, cyte just means cell. So we have a monocell and a megalokaryocell. So a proerythroblast would actually make a what? A erythrocyte. A erythrocyte. Pro in this case means before. So this is before urethral build. When we build the urethro, we're going to be making a erythrocyte. The only exception to this rule would have to be the myeloblasts. Because these guys actually make 4 different things when they develop. And I'll name them from the most created to the least created. So for myeloblasts, from the myeloblasts, we're going to be creating the neutrophils, the eosinophils, and the basophils. You're probably wondering, well, why are they called this? Well, neutral kind of sounds like neutral, and basophil means basic or alkaline. So when scientists were staining cells under a microscope, they would use different stains. Now, some stains would be acidic, some stains would be alkaline, and some stains would be a pH of 7, which is neutral. And depending on the pH of the stain, these different cells would take on different colors. So neutrophils became really, really easy to spot when you use a neutral stain. Eosinophils are red-orange, so this is red-orange, because we're using a stain called eosin. And here we have the full development of these cells. So platelets actually are derived from the megakaryocyte. So we can say that platelets are derived from megakaryocytes. And actually, platelets are these little fragments. So if I took a knife and I slice this guy and I slice here, and I start breaking down this megakaryocyte, I'm going to derive platelets. It's kind of like breaking off a cookie. Eventually, you break off the chocolate chip parts of the cookie, and those little chocolate chips are going to be functioning as the platelets. But let's say that you don't eat the bread portion of the cookie. What do you do with it? You recycle it, or you throw it away. And so what happens here is that macrophages will actually break down the worn out megakaryocyte and recycle it so that it can create more megakaryocytes. The macrophages are actually derived from the monocyte. So this is a macrophage. And the whole purpose of a macrophage is to act kind of like the janitor and also security guard of a university or school. And so the janitor will go around the school cleaning up debris, cleaning up the walls and whatever, and getting rid of the trash, recycling the recyclables. But also the janitor will have a walkie-talkie and is going to say, hey, I see some germs in this part of the body, let's send some people over here. And so the monocyte will actually eat the bacteria, it'll get rid of the bacteria, and is going to call other cells to that area. Here we have one of the most important processes, which is called the myeloblast, which gives rise to the neutrophils, the eosinophils, and the basophils. These guys right here are actually your leukocytes. Leukocytes. Leuko means white, and cytes means cell. So these guys right here are your are your white blood cells. So previously when I put white blood cells here, what I really should have put was lymphocytes. Lymphocytes, because the following cells reside in lymphatic tissue or the lymph nodes or in the lymph fluid. But these guys right here are going to be part of your immune response as well, and so are the lymphocytes. Now, finally, we also have the prourethroblast converting into something called a reticulocyte. Well, the prourethroblast is actually going to create the erythroblast, and from then on is going to create the reticulocyte, and from then on is going to create the erythrocyte. Now, you're probably familiar with the concept that red blood cells or erythrocytes have no nucleus. So this is no nucleus. They don't have any ribosomes, no mitochondria, no organelles. So they don't make proteins. They don't make as much energy as other cells. Well, why don't they have a nucleus? The erythroblast and even the prourethroblast, they have a nucleus. But when the erythroblast converts into the reticulocyte, it loses organelles. The reticulocyte is kind of like a premature erythrocyte. And so the whole purpose of a red blood cell not having any organelles is because you want to be as empty as possible so that you can stuff yourself with oxygen. So the more space we lose, the more space we gain for oxygen. We get rid of the mitochondria and instead we put in oxygen in its place. And so the erythroblast, when it's maturing into the erythrocyte, it will reject its organelles and become the reticulocyte. And the reticulocyte converts into the erythrocyte. And now let's say that the body needs to create lymphoid cells. So instead of going into the myeloid process, we're going to be doing the lymphoid process. So the lymphoid process, it creates, again, the lymphoblast. So again, blast means to build. What are we making? We typically make lymphocytes. So blast usually follows before cytes. Why do we call them lymphocytes anyways? Well, these cells typically will go into the thymus. They typically go into the thymus, which is a little structure for the immune response. As you age, the thymus will deteriorate, and I'll pull up a picture later. And we also have some tissue, some cells going into the spleen or the lymph nodes or the lymphatic fluid. What we gain from this is the natural killer cells, and we also have the T lymphocytes and the B lymphocytes. We also call these guys T cells, or these guys B cells. But really, it makes more sense to call them lymphocytes, since it helps you to remember that they are lymphocytes. But why do we call this a T cell, or a T lymphocyte? Well, the T lymphocyte will mature inside the thymus, and the B lymphocyte is going to mature inside the bone marrow, specifically the red bone marrow. So think of these guys as soldiers. So these guys right here are soldiers. And first you go into basic training, and after that you specialize or you deploy. So for this guy right here, the B lymphocyte, they're going to be made in the bone marrow. Well, this guy too, he's also made in the bone marrow. That's like basic training. However, the B lymphocyte stays inside the bone marrow. B is for B lymphocyte, B for bone marrow. So he's in the army, he trains in the bone marrow, and then he specializes in the bone marrow. For the T lymphocyte, he's made in the bone marrow, but then he exits the bone marrow and instead goes to the thymus for specialized training and maturing. And for the natural killer cells, also known as the NK cells, they are also in the red bone marrow. And then they leave the red bone marrow and they can circulate all around the body. They can go to different organs, they can go to the lymph nodes, the spleen, wherever they want. They just kind of act like the patrolmen of the immune system. And we'll learn more about our friends when we study immunology. Now, before I leave this page, I just want to mention that we have two different types of cells. We have the granular cells, and we also have agranular cells. So granular just means that we have little granules inside the cytoplasm. You can kind of think of this as freckles when you look at them under a microscope. So these freckles have different enzymes. They may have histamines or lysosomes or peroxide to help kill bacteria. And here, for the most part, lymphocytes are actually agranular. That means that they don't have these little freckles or granules. If you look closely at this guy, at the T lymphocyte or the B lymphocyte, they don't have any grains. The exception to this is the NK cell. Here we have these little freckles inside the natural killer cell. So this is the exception. It actually does have granule tissue. It actually has granules inside the cytoplasm, but it's derived from a lymphocyte. Here in the white blood cells, these guys for the most part are granular. So when we blow up a picture of these guys, we're going to see little freckles all around here, like that. And those are granular. So they're going to be releasing lysosome or peroxisome. They may have histamines that do all sorts of different things inside the body. The exception to this is the monocyte, also known as a macrophage. Macrophage, when it fully develops. The macrophage has no grains. It is agranular. And yet it acts inside the immune response and is derived from the same pathway as the white blood cells, meaning the myeloid stem pathway. So those are the two exceptions. So the macrophage is actually agranular, the natural killer cell is actually granular, and for the most part, the white blood cells are granular, meaning they have these little granules inside, and the lymphocytes, for the most part, do not have those grains, and so we say agranular. So here we have the lymphatic system, and behind the sternum, we actually have the organ called the thymus. It's right there. So the T cells, which are derived from the red bone marrow, they will actually go into the thymus for further training. And the thymus helps in the immune response. And as you age, the thymus atrophies, so it becomes smaller and smaller and smaller, and that's why you have older people who are more prone to being sick or to being infected with bacteria, because the thymus can no longer elicit such a strong immune response. You're probably wondering, well, how does the body signal itself to even make red blood cells or platelets or white blood cells? Well, the body signals itself using growth factors. So we have the hemato, we're just going to call this H, hematopoietic growth factors. If we want to make erythrocytes, we're going to be using the erythropoietin. If we want to make platelets, which are called thrombocytes, which means platelets, well, guess what? We're going to be using thrombopoiesis. What if you want to make leukocytes, which are the red blood cells? Well, those are a little bit different. Those are called cytokines. And that makes the white blood cells. And all three of these hormones, the erythropoietin, the thrombopoiesis, and the cytokines, these guys are glycoproteins. And so is this guy. It's a glycoprotein. But we have to ask ourselves, why would we signal for this growth factor in the first place? Well, for erythropoietin, we're going to call this EPO, erythropoietin. We do this when the concentration of oxygen is depressed. So the fibroblast tissues in kidneys, they sense that there's not enough oxygen around the tissues. So the fibroblastic cells inside the kidneys say, hey, we got to increase the amount of erythropoietin inside the kidney. And so the kidney secretes erythropoietin, and this guy will increase the erythrocytes, or the red blood cells. When you increase the amount of erythrocytes, the body has more of a chance to get every bit of oxygen inside the blood. So it's kind of like the body's plan B when you don't have enough oxygen. If you don't have enough oxygen, well, you better start making more red blood cells so that the oxygen that there is can be pushed into the red blood cells and circulated around the body. It's kind of like sucking harder on the straw when you're out of soda. Well, the erythropoietin just makes the blood multiply, the red blood cells multiply, so that it can gather as much oxygen as it can. And this sounds great. I mean, why wouldn't we want more oxygen in the body? Well, when you do this, like I said, the more red blood cells inside the body, the thicker the blood. So this increases viscosity, or the thickness of the blood, which actually increases the blood pressure. It increases the blood volume, and it also increases the strain on heart. So on the heart. So for athletes, they would often go to maybe Denver, Colorado, or to the Himalayas, and they train so that they can increase the amount of red blood cells in their body, because the body senses that there's not enough oxygen, and so it increases erythropoietin, which increases the amount of erythrocyte production. So when they go back to the training event, or actually the the event itself, they have more red blood cells and they can deliver more oxygen to their tissues. So now they are, supreme athletes. And that's actually pretty legal. What's illegal is when you actually make these synthetic. When you have the synthetic version of erythropoietin and you inject it, the hematocrit value is going to shoot up. And Lance Armstrong actually did this. He was blood doping with erythropoietin, and furthermore, he did this without erythropoietin. So if you do this without erythropoietin, it's when you take your red blood cells, you take them out, you put oxygen in them, and then you freeze them, and your body replenishes the original red blood cells. It takes about 5 weeks. Afterwards, about 24 hours before the main event, you go back to the freezer, wherever you have your red blood cells, and you re-inject them into your body. And now you have 100% red blood cells plus the extra that you just put in, and now you're supercharging your body with oxygen. And that allowed him to win the Tour de France like more than 5 times. Erythropoietin can actually be given to cancer patients, especially after they did cancer treatments. They have a decrease in hematocrit, and you would inject erythropoietin and that increases their hematocrit value. So it can be used medicinally. Moving on, we also have the thrombocytes being created by the thrombopoiesis. And the thrombopoiesis, that is made by the liver and kidneys. It actually increases the production of megakaryocytes, and it also increases the rate at which the megakaryocytes break off and form platelets. When you have a deficiency in megakaryocyte, you form something called thrombopentasia, which is a depression of platelet volume inside the blood. And so when you get a cut, it's very difficult for the bleeding to stop because the platelets are not as plentiful and they don't stop the blood as quickly as they ought to. Now, the last guy, the cytokinins, these actually are a little special because there are 2 types. There are 2 types. First are the interleukins, and the next are actually colony. They're actually colony stimulating factors. So the interleukins, a long time ago, scientists thought that the interleukins were like the walkie-talkies that the white blood cells use. You have one of the neutrophils, they have a little walkie-talkie with a little signal, and then here's a basophil. And he also has a walkie-talkie. And this guy is like, hey, I'm going to get some tacos over. And then the interleukin, which we're going to label as IL, not I1, but IL, let's say interleukin 1, takes that signal and he relays it to this basophil. And the basophil is like, okay, I'm going to get a quesadilla over. And then interleukin, 6, takes the signal and sends it over to the neutrophil. Scientists thought that this was the case, but it turns out that the interleukins themselves can affect the growth or proliferation of other tissues or cells. And so that's not necessarily the case anymore. But when you name interleukins, you name them as interleukin 1, interleukin 2, interleukin 3, etc. But the main guy that we use for the cytokinin, the more important one, that's actually going to be the colony stimulating factor. And we're going to be stimulating the white blood cells, also known as leuco, which means white, and cytes, which means cells. So white cells, white blood cells. It's easier if you remember that these guys right here are actually, for the most part, granular. And so we can have something called the granular colony stimulating factor. And what is that going to stimulate? Well, that's going to tell the body to create the neutrophils. The eosinophils, and the basophils. Well, what if I want to make monocytes? What do I make? If you want to make monocytes, you make the monocyte colony stimulating factor. And that just makes the monocytes. So it increases the creation or differentiation. Well, what if the body wants to make both the granular and the monocytes? Because remember that the monocyte is an exception in which it is agranular. But let's say that we're fighting off a bacteria and we need all the manpower we can get. And so we got to call the monocytes to make the macrophages so that they can nibble on the bacteria. And so instead of calling this, a combination, we would just call this the the granular monocyte colony stimulating factor, which is so silly. But we call this the GM, colony stimulating factor. The G going for granular, the M going for monocytes, colony stimulating factor. So that makes the neutrophils, which are granular. When you're writing it down, always repeat to yourself what they are. The neutrophils are granular. The eosinophils are granular. The basophils are granular. But the monocytes, which make the macrophages, the monocytes are agranular. Well, okay, that explains the white blood cells, but if we have a cut and all that bacteria is entering the body, well, I understand that we have to make white blood cells, but shouldn't we close down that cut? But yes, we should. And so instead, we're going to be making platelets. Well, if we're going to be making platelets, we might as well be making white blood cells so we can kill the bacteria and then close the cut. And so when we want to incorporate platelets or thrombocytes, we're going to be making the whole army. And so we're going to be making something called the multi colony stimulating factor. And that creates the neutrophils, the NPs, the eosinophils, the EPs, the basophils, the BPs, the monocytes, the MCs, which are actually agranular. And then you have the thrombocytes. So this is the thrombocytes, also known as platelets. And so you can see here that a major factor in the immune system would have to be the cytokinins, or the cytokines, because of the colony stimulating factor. You're making a colony of granular white blood cells. You're making a colony of monocytes. You're making a colony of both the granular white blood cells and the agranular monocytes. And then if you want to throw everything at the bacteria and the cut, you want to make thrombocytes. And so you just make the multi-colony stimulating factor. So going back into the blood, we will now be focusing on the individual items right here, the individual items. First, we're going to be talking about erythrocytes, which you know comes from the myeloid process. First, you're going to have to make the myeloid stem cell, and then you're going to make the pro-erythroblast, and then the erythroblast and the reticulocyte, and finally you have the erythrocyte. So let's hide everybody else. And here we just have these guys. So what can we tell about the shape? So the shape kind of reminds me of a pancake or a donut, but this is called a biconcave shape because it kind of caves in on itself on both sides. And the reason why it does this is because it wants to make as much area as possible so that it can stuff itself with oxygen. But why is it red? Well, it's made from hemoglobin, and hemoglobin allows the erythrocyte to carry oxygen to different parts of the body. And let's pull up a picture of hemoglobin. Here we have something called the hemoglobin. And this allows for the capturing of oxygen. So we're going to call this oxygen. The hemoglobin is made from 4 different types of proteins. You have the first alpha chain, you have another alpha chain, so there's 2 different types of alpha chains, and 2 different types of beta chains. Each chain has something called a heme group. So it's this little disc, and this heme group is made of oxygen. The heme group is going to be capturing the oxygen. Since there are 4 heme groups, 4 hemes, that must mean that we can capture 4 oxygens. Oxygens. Right there, that's a Y. Okay. And within each erythrocyte, so the little disc that I showed you, that single disc has 300 million hemoglobin. And since each hemoglobin can capture 4 oxygens, that must mean that we have 1.2 billion molecules of oxygen in just one red blood cell. And frankly, that's really amazing, because not only does it show you how compact the hemoglobin is stuffed inside the red blood cell, it also shows you how small a molecule of oxygen really is. The reason why blood is so red is because the more oxygen that binds to the hemoglobin, the brighter it becomes. So if we have 4 oxygens, right there we have a bright red. So in arteries, let's say that the arteries just left the lungs, well, the blood that just left the lungs, they're completely filled with oxygen, and so you would expect them to be bright red. The veins, which have little oxygen, they are going to be dark red. So this is a darker red. It's almost like a brownish red type color. However, you should know that hemoglobin rarely gives up all of its oxygen. There's always going to be at least one heme group that has oxygen attached to it. And pretty intuitively, when we have hemoglobin attached to an oxygen, so when we have a hemoglobin plus an oxygen, we call it the oxyhemoglobin. The oxyhemoglobin. And that's going to be bright red. Bright. When we take away oxygen from the hemoglobin, we're going to call that deoxyhemoglobin. Hemoglobin. And that's going to be darker. When you're working with pulse oximeters, the little machines that stick on your finger, they have a red light and an infrared light. The reason why is because that light will be absorbed differently by hemoglobin. So the light waves are going to hit the hemoglobin and it's going to go back into the machine, and the machine calculates it, doing fancy computer nerdy stuff. Who really cares? You just want the value. But depending on how saturated this hemoglobin is, it can give you a percent saturation in the blood. So for instance, anything 95% and above, that's going to be good. So that must mean that 95% of the hemoglobin is saturated, which is good. Anything 95 or let's say 94% and below is going to be bad. So that's bad. That must mean that 94% of the hemoglobin inside the blood is not saturated, and that leads to you could say hypoxemia. This is actually low concentration of oxygen inside the blood, and we never want that. But hemoglobin cannot only take in oxygen, it can also take in carbon dioxide. So let's say that here we have oxygen and another oxygen, right? When this oxygen leaves, instead we have carbon dioxide kind of floating around the blood. Carbon dioxide is going to see these 2 empty spaces and it says, hey, I got to get out of here. I got to go back to the lungs and be exhaled. Because you never want to build up a lot of carbon dioxide inside the blood or in the plasma. So now carbon dioxide is going to bind to this hemoglobin so it can take a taxi outside of the body, into the lungs really, to be exhaled. And when the carbon dioxide combines with hemoglobin, so you have carbon dioxide plus hemo, you're going to have something called carb amino carb amino hemoglobin. Carb amino hemoglobin. Now, a vast majority of carbon dioxide, about 75% of carbon dioxide, goes into the plasma, so it kind of evaporates into the plasma. And when that happens, it makes a bicarbonate. So it makes a bicarbonate right there. So this is a base, and it helps manage the blood pH. And then the 25% of carbon dioxide will go into the hemoglobin to form carbaminohemoglobin, and that goes into the lungs, and the lungs exhale the carbon dioxide, and then they inhale the oxygen to form oxyhemoglobin. And we have to know that for the red blood cells, also known as the erythrocytes, or we have the red blood cells, they have to be recycled every 120 days. So every 4 months they have to be recycled, and therefore you have to be recycling the hem groups and the proteins, the globulins. So for the globulin portion, this is actually the protein that makes up the hemoglobin. Well, it has to be broken down into amino acids. And these guys right here, they go to the red bone marrow, and that must mean that they're going to be reused to make more red blood cells, because red blood cells are made from proteins, and we're going to be reusing the amino acids to make more red blood cells. Now, for some hemoglobins, the kidneys are going to do something special. The hemoglobins are going to be broken down into their beta chains and into their alpha chains, and then the kidneys themselves are going to filter the alpha chains, they're going to filter the beta chains, and then they're going to resend these alpha and beta chains into the bone marrow so that it can create more hemoglobin. But what about the heme group? What about this iron? So remember that this guy right here is called the heme. What happens to the iron? Well, the iron is kind of snatched from the hemoglobin, and it's stored inside the liver and the spleen. So this goes to the liver or spleen, but it has to take on a different form. So this iron has to be converted into something called ferritin. You can also create something different called hemocedrin. That's an E-R-I-N. And so these are two different forms of iron, and the body stores the iron as ferritin or hemocedrin. Now, this is actually advanced right here, but I picked this up when I was at the clinic, when I was getting into med school. So ferritin is something called an acute phase reactant. And what ferritin does is that you can see if the body's fighting inflammation. So let's say that you're running a fever. Okay, very simple. Let's say that you caught just the common cold, and you have a fever and you're burning up. Well, you have an infection. And if you were to do blood work, you would notice that the ferritin levels are going to be markedly elevated. And so when you're looking at blood work, you can see the ferritin and you say, hey, I know one of my patients has a ferritin level of maybe 300. Well, that's really elevated. And so you could say, for some reason, you're fighting some sort of infection. And that gives you a clue into different types of diseases or whatever condition your patient may have. So ferritin is called an acute phase reactant. But anyways, now that we're storing the heme in the form of ferritin and hemocedrin, we have to ask ourselves, how are we getting this iron back into the hemoglobin? Well, when we need to create red blood cells and we need that hemoglobin, we will transfer this iron from the ferritin or the hemocedrin into a transport protein. And this transport protein is called transferrin. So the iron is locked up inside ferritin and hemocedrin. The body says, hey, we need to move the iron from this form into the red blood cells. So we're going to load them onto a bus and transfer Fe into the red blood cells using transferrin. But before that, you can imagine the iron. Here's iron 2 plus. Well, it has to get ready to work. So it has to take a shower, it has to eat breakfast, it has to change clothes. When it's ready to go to work, it will be positive, it will be oxidized, and it will take on a different form called Fe3 plus. So it is actually the Fe3 plus that will only go into the transferrin, because now it's ready to go on the bus and get ready to work. It has a positive attitude and a positive outlook on life, and it says, hey, let's make up some hemoglobin and let's get some oxygen. So recall that transferrin only transfers the oxidized version of iron. So this goes into transferrin. Well, and this is like the bus, by the way. So we have the little wheels, and this is the hood, and we have this little driver right there. Well, the driver that drives the transferrin bus with the little workers, that is called ferroportin. So that is ferroportin. So he is going to be he's going to be driving the transferrin into the red bone marrow. So he is kind of like a portable driver. Okay, so iron goes into the transferrin bus, and it's only Fe3 plus, and ferroportin is going to be signaling the transferrin to be transferring the iron into the red bone marrow. Now that we've converted the beta chains and alpha chains and the heme groups into different things like amino acids and iron, we still have little particles of hemoglobin left. Well, we're going to take these particles and we're going to convert them into something different. And instead, we're going to convert it into something called biliverdin. So if you speak Spanish, verde means verde, which is green, or French, which means verde, and verde means green. And bili, because we're going to be entering the bile duct, which is in the gallbladder. So this is in the biliary system. So these little particles of hemoglobin, well, it was hemoglobin, but now it's broken down. These particles are further broken down, and they're converted into biliverdin. Verd means green. So we go to the liver, and the biliverdin is further broken down into something called bilirubin. The bilirubin is actually yellow. So here we are. This is a yellow pigment. The bilirubin will then be converted into bile. So bile again is going to be called a green color. So this is bile. And the reason why we have bile in the gallbladder is that when we eat fat, like let's say we're eating barbecue and we're eating those little packets of fat that we love so much, the bile will help to surround the dietary fats, and that helps the body move the fat easily within the intestines and to digest the fats easily. So this helps with fat digestion. Fat digestion. From then on, we're going to form something that's actually colorless. The bile is going to be broken down by bacteria. So we have bacteria breaks bile, and it forms a colorless substance called urobilinogen. So bacteria is going to separate the bile into two parts. We have bilirubin and urobilinogen. So in Spanish, rubio means blonde. So that's another way Spanish speakers can kind of learn this. Bilirubin is yellow, rubio is yellow. So it breaks down the bile and separates it into two different parts. We have the urobilinogen, which has no color, and we also have bilirubin, which is yellow. So let's move over here. From then on, we have two processes. So we have urobilinogen can form two different things. We have urobilin, and we also have something called stercobilinogen. So gen means to generate something. We're going to be generating stercobilin. So stercobilin. So what is stercobilin? Stercobilin is actually a brown pigment, and that gives human excrement the color brown. This comes from stercobilin. Urobilin is actually yellow, so that gives the urine the yellow color. So going back into this entire process, the heme particles, or I guess the hemoglobin particles, are further broken down into biliverdin. The biliverdin goes into the liver and it converts into bilirubin. Bilirubin becomes bile that helps us digest fat. That bacteria then break down the bile, they separate it, and they separate it into urobilinogen. And we also have bilirubin being reformed. From then on, urobilinogen has two options. Either it becomes urobilin, and that gives the urine the yellow color, or it can further be processed into stercobilinogen, which will be processed as stercobilin, which is the brown pigment in human excrement. Here we have a disease called jaundice. This is actually jaundice, and it's French for yellow disease. And so notice that the skin has a yellow pigment, and that's from the high accumulation of bilirubin in the body. And particularly the sclera of the eye, the white portion of the eye, is really yellow. And that's because the sclera have a specific protein called elastin, which really loves bilirubin. So it loves bilirubin. And this is adult onset jaundice. Children can also have jaundice, but in adults, we typically leave it alone and it passes. But sometimes it has to have surgical intervention, like let's say the little tubes inside the bile duct are clogged, so we have to go in there with surgery and unclog the biliary system. Jaundice, when it's treated, it's because maybe there's hepatitis, so like the liver is actually inflamed. Or you can have something like a heme breakdown. So heme breakdown. So like the heme groups keep breaking rapidly, so we have to find out why the red blood cells are breaking down. So that's an underlying cause, and jaundice is one of the symptoms of heme breakdown. And actually, I had a patient once. She was in the office and she had jaundice. This was an Asian American woman who had jaundice, and she was in her late 40s. And I found out that she had a mass in her liver. So when we palpated the area, she had this very sharp feeling during a palpation. And it turns out that she did have a mass. Now, for erythrocyte formation to occur properly, you're going to need three different things. Well, really four different things. First of all, you're going to need copper. You're going to need zinc. And then you're going to need some B vitamins. So specifically the B vitamins you're going to need is B9, which is folate, which is actually, you can say, folic acid. And then B12. So these guys right here are water soluble. And what B12 does is that it's going to be acting as a coenzyme. So we have a coenzyme that helps in the production of DNA. So we have DNA synthesis. and therefore it helps to make new cells. Makes new cells. And so does B9. So these guys right here, they help to do DNA synthesis and helps to make new cells. And so obviously you're going to need B9 and B12 for proper red blood formation. For the zinc, the reason why we need zinc is because this helps form the heme group. So this helps form the heme group formation. If we have good heme group formation, that allows the hemoglobin to grab the oxygen from the plasma and to transfer it to the cell tissues. And also this is a coenzyme. Now the copper is very special. So we're going to differentiate this, or I guess denote this as copper. So copper right here, let's do this in a different color. You have two different portions of copper. And the first one is going to be called Hephaestin. So we have Hephaestin. And Hephaestin has copper in it, but this allows the intestinal cells to digest or to absorb iron easily. And the next one that we have is called ceruloplasmin. And ceruloplasmin allows the body to absorb copper. Absorbs copper. So the reason why we need copper in the first place is that the body needs that copper to activate Hephaestin, which allows the body to get dietary iron easily. But what if we have a deficiency in something or a malfunction? What if we don't have ceruloplasmin? Well, if you don't have ceruloplasmin, you don't have the copper being absorbed. And so the amount of copper, the concentration of copper will increase. And that is really bad because this leads into Wilson's disease. And the reason why I'm mentioning it is because I know a person, she's a patient, and this person has Wilson's disease. So here is Wilson's disease. So here we have a dead giveaway for Wilson's disease. Normally this individual would be having blue eyes, but in Wilson's disease, you have this ring around the eye, and this ring is copper colored. So this ring right here that you see is called a Kaysa Fletcher ring. Kaysa-Fletcher ring right there. So this ring accumulates because the copper levels in the body have increased. When you have copper levels increasing in the body, the copper goes into the organs, it goes into the tissues. A lot of people with Wilson's disease will have complications within their liver, and overall they're going to suffer from systemic organ damage. A lot of people with Wilson's disease are going to have shaking in their hands, so their arms are going to be swaying around. They might have trouble speaking to you. They might speak like this, and they might repeat words, and it's hard for them to kind of talk. And when they're doing this, you'll notice fine tremors in their hands. You'll often see them following up with a hepatologist, with a physician who studies the liver, because there are a lot of complications within the liver. So we have liver complications. You also have tremors. And since we have liver complications, another thing that may arise is jaundice. So we have jaundice, which we just saw. We can have liver cancer. And sometimes, especially for this patient, they underwent a liver transplant. There's also neurological effects of Wilson's disease. For instance, you might have a person who is depressed or anxious, and that could just be from living with Wilson's disease. It's very debilitating and it's chronic. You can never truly fix Wilson's disease. I mean, you can give zinc, because zinc will actually snatch some copper and take it out of the body, but even then, it's not truly going to alleviate or solve Wilson's disease. You also have Parkinsonian factors of Wilson's disease. It's very similar to Parkinson's, in which you're speaking to a person with Wilson's disease and all of a sudden their arm is shaking heavily, and it's kind of like they're just kind of waving and they're speaking to you, and they have no control over it. And so they have really either gross, which is like very exaggerated, or fine, or fine tremors. And they might be clumsy when they walk. They have kind of like a gait to their walk. They might be shuffling while they walk, and they're prone to falling. So you have to be very careful with individuals with Wilson's disease, because they have a lot of systemic issues going on. But once you pair a disease with a person, or you see it in real life, it sticks with you. And this is because there is a lack of ceruloplasmin, and therefore the levels of copper are elevated inside the body, because copper will grab onto ceruloplasmin. So here we have the blood once again, and we are almost finished covering the red blood cells, or the erythrocytes. So notice that we have this nice biconcave shape, and the way that we maintain this shape is through the usage of a cytoskeletal protein called spectrin, 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 and it allows the red blood cell to fold on itself and to fit into tight places. Now, sometimes the red blood cells, when they're in a large artery, they will kind of stack up like donuts, and that is called a rouleau. It's French for roll. It's like a roll of of red blood cells. So that is red blood cells. And now we just finished talking about erythrocytes. So we can focus on leukocytes, which are the white blood cells. And that, again, that's made in the myeloid process. For leukocytes, or white blood cells, they're going to be granular, except for macrophages, which are actually agranular. They're the exception. But we're going to start with the most produced, and that is the neutrophils. So the neutrophils, right here, have these little freckles, and these are called granules. And neutrophils are the first responders. They're kind of like the paramedics of the immune system. So when anything happens, the neutrophils will be right on the spot, quick as can be. And they're going to be phagocytic, meaning that if they see a bacteria, they're going to munch on the bacteria. They're a really good munch. And you can see that the nucleus has multiple lobes. So the younger the neutrophil is, the least amount of lobes it will have. When the neutrophil is older, you will have more lobes. So that's actually going to be called morphonuclear. So that is polymorphonuclear when it's older and has more lobes. Typically they're going to stain kind of clearish blue, because it grabs stains that are neutral, like in the pH scale, a stain that would be a pH of 7, which is neutral, it will stain pretty well for these neutrophils. Now inside these granules, they have little enzymes. So you can have lysozyme, which are enzymes that will cut things. So let's say we want to cut a bacteria, we're going to spray our lysozymes at that bacteria. You can also have hydrogen peroxide, and hydrogen peroxide is also going to kill a bacteria. So you can see that neutrophils are really the primary defense. So it's like the main responder when you have a cut. Oh, and finally, you also have defensins inside these little granules right here, defensins. like you're playing defense. And defensins are like the little knife for the neutrophil. So it will go to a bacteria and it will, stab a bacteria, and that helps pop the bacteria. So that is a neutrophil. And if you notice on a blood exam, the neutrophil level is high, well, most likely this person may be dealing with an infection, like a bacteria infection. Another reason that you may see high neutrophils is because you have a burn victim. So let's say that this person was in a fire and they lost like 10% of their skin. Well, their neutrophil levels are going to be elevated because a lot of their skin or a lot of their body is exposed to the outside elements. And so the body is surmounting an immune response to prevent any bacteria from entering the body. Because we have to realize that the skin is a large organ which prevents the body from coming in contact with the bacteria or pathogens. So you're going to have an elevated level of neutrophils with burn victims. The next leukocyte that we'll be talking about is actually the eosinophils. So the eosinophils, if we compare it with the neutrophils, we will notice that the eosinophil is reddish orange, and it's also larger than the neutrophil. So the reason why it's reddish orange is because it grabs acidic stain material easily. So typically when we stain eosinophil, we will use a stain material called eosin, which is acidic. And eosinophils are phagocytic, so that must mean that when they come in contact with something, they will phagocyze it. They will actually eat it, quote unquote eat. And notice that there are little granules inside. So this is a granular leukocyte. It is the second most produced leukocyte in the body, second to the neutrophil, right there. Now notice that inside the granules we can actually have something called histamines, which is a non-specific immune response. So when you have allergies, just to oversimplify it, when you have allergies, the eosinophils will look at it and they say, hey, I don't like this. I'm going to release some histamines to reduce or to actually increase an immune response. So that's why you have a runny nose, you have a stuffy nose, your face gets red and you start sneezing. That's because you have eosinophils releasing their histamines. Now, when you have a parasite inside of you, let's say that you ate some oysters and now you have food poisoning and the doctor says you also have a parasitic infection, well, the amount of eosinophil production is going to go up. So they're going to release anti-parasitic molecules to try to kill the parasite. And they're also going to release histamines. So you may have allergies or you may have a parasite. It's always going to release histamines. And it's going to try to kill those parasites. And when you take something called Zyrtec or an antihistamine like Benadryl, you're trying to reduce the amount of histamines in the body that is being produced by these eosinophils. And before we move on, eventually when we do have allergies, we don't stay sneezing and having a runny nose forever, because the eosinophil will end its histamine secretion. And let's say that there's little histamine molecules floating around. Well, the eosinophil will release an enzyme called histaminase, and histaminase will take that histamine and deactivate it. And so now you have a decrease of histamines inside the blood. And so it reduces the histamine reaction over time when there's no need to be allergic anymore. In addition to that, the inflammation that you see, so when your face gets red or your skin gets red, like you have an allergic reaction to a bracelet made of metal, well, that contact irritation, that eventually goes away because the eosinophils will release molecules that will reduce the inflammation in that area over time. And now we also have these very large guys right here, and this is called a basophil. So out of all these blood cells, out of all these elements right here, where we have the eosinophils and the neutrophils, there's only one basophil. And it's all lonely because basophils are not formed that much. But notice we have a massive amount of these granulocytes, of these granules. So these granules right here are going to also have histamine. So when you have an allergic reaction, they're going to release their histamines. And there's also going to be heparin. So basophils will release heparin, and heparin will prevent coagulation of the blood. But it releases heparin at specific times, and it's not always going to release it. Here's a fun fact. These granules can also release serotonin, but again, you would have to have a specific signal for that serotonin release. So there's a time and place for everything. And the reason why we call them basophils is because the stain that we use is basic. It is alkaline. So it would be like a pH of 10. And it grabs basic stain really well. And there's usually one lobe for the nucleus. So it's kind of like a lima bean inside this basophil. But they're larger than eosinophils. So here's a side-by-side comparison. You can see how large this basophil is. So now we'll be talking about the agranular cells. So here we have the macrophage. So recall that the macrophage is derived from the myeloid process, and they are, the exception for the white blood cells. These guys are not lymphocytes. They don't go into the lymphoid tissue. They don't go into the thymus or anything. They kind of wander around the capillaries and the arteries, and they just kind of clean up the cells. So let's say that this red blood cell is old. We have to recycle it every 120 days. And so it'll eat it up. It'll be phagocytic, and it's going to recycle it. It'll grab the little pieces and transport them somewhere else, like a janitor. But, like I said, the janitor can also be a security guard. And so if there's a bacteria, my cursor is a bacteria, and I'm sneaking around being evil, well, guess what? The macrophage will, it'll phagocytize it. So it's going to get it and is going to break down the bacteria. Now this is pretty special because with the phagocyte, with the macrophage, it will actually break down the bacteria and wear bits of the bacteria on its surface. And what does it do with that? Well, the macrophage is going to move to one of these guys. It's going to move to a lymphocyte. Now, there are three different lymphocytes. Let's say that this guy right here is a T cell, a T lymphocyte. So the T lymphocyte is going to be working with the macrophage and is going to get that body part for the bacteria, for lack of better words, and is going to say, hey, I see that you're wearing some bacteria, so there's a bacteria infection going on. Let me call the other T cells, and we're going to get onto this. And so you could say that this guy right here is helping out the T cell. So this is like a T helper cell. So when the macrophage finds bacteria or a pathogen, it will wear part of it and present it to the T cell, which is a lymphocyte. And notice that the lymphocyte has no granules. So T cells, which are T lymphocytes, and B lymphocytes, they are represented by this guy right here. So this is a lymphocyte and they have no granules. In addition to this, let's say that this macrophage ate a bacteria. When it eats the bacteria, it's going to release chemical trails. This is called defensin, and there are some other chemical trails as well. And what that does is that the lymphocytes right here are going to sniff that chemical trail, and it says, hey, this guy right here left a trail. Let me go follow this trail. Let me go to that area and see if there are any other bacteria around here. And this is called positive chemotaxis. So chemo is chemical and taxis means to move, like a taxi. So the leukocyte right here, actually not the leukocyte, but the lymphocyte, will follow this positive chemical trail that is secreted by the macrophages. And it's going to be looking around like a little dog, sniffing around for some treats. For B lymphocytes can differentiate into plasma cells. And plasma cells are created in the red bone marrow within the bones. And what plasma cells do is that they will shoot out antibodies which will connect onto other cells. So let's say that this cell, my cursor is one cell, and my cursor has cancer, so it's a cancer cell. On this cursor are little antigens, which are markers that say, hey, I'm abnormal, I should be eliminated. So it's going to express these little antigens, and the antibodies, which are being shot out by the B lymphocytes, will connect to the antigens that are being expressed on my cursor, and it's going to target me. It's going to mark me for deletion, pretty much. So natural killer cells, which are another lymphocyte, are going to bind to my cursor, and it's going to eliminate the cancerous tissue or cancer cell. Now, both B lymphocytes and T lymphocytes can have memory cells, and memory cells can last for years within the body. So let's say that you once had E. coli when you were, 20, and then a couple of years later you get E. coli again. Oh my gosh. So the B cells and the T cells, they have memory cells, and so the body says, hey, I remember when we had E. coli, we did this, we secreted this amount, we had this specific T cell, or we had this specific B cell. And so now the body will start making those specific B and T cells that are specific for the E. coli or whatever bacterial infection that you have. And just to leave no stone unturned, this right here is just a platelet. So it is a piece of megakaryocyte, which is derived from the megakaryoblast, which is a part of the myeloid stem process. And that helps to kind of close down gaps within the capillary or artery, and it helps kind of close up those cuts. So that's a platelet or a thrombocyte. And that is it for this lecture. So that is kind of like the introduction to hematology, and hopefully you learn a little bit more when you're studying hematology. But now you know what a erythrocyte is, hematocrit, what a lymphocyte is, a leukocyte, the myeloid process, the lymphoid process, all of those great things. And plus you even learned about jaundice and Wilson's disease. So I hope that you had fun, and I hope that you know that you are loved and you're amazing, and that you can learn anything you put your mind to. Alright, so take care, and I love you. Bye.